Hi everyone. Um, Today we're going to be talking about adrenal gland disorders. This is the third video lecture for this academic half day. So I'm going to be doing two videos related to adrenal gland. One will be focusing on adrenal gland disorders, and the second one will be focusing on CAH as requested during the first academic half day. Um, so let's begin our adrenal gland talk. So remember, when we talk about adrenal gland disorder, in endocrinology, we focusing adrenal cortex, right? Remember from embryology, there are two zones. There's cortex and adrenal medulla. So adrenal cortex is derived from mesoderm, but the adrenal medulla is from neuroectoderm. Remember this? I'm going to be asking you during the challenge quiz again. So it's from neuroectoderm, right? So this is the histology, right? So when we talk about the cortex, there are three zones, right? Zona glomerulosa, zona fasciculata, and zona reticularis, right? This is chromaffin cell, which belongs to the medulla. So when we talk about the hormones, there are three hormones that we refer to adrenal hormones: aldosterone, cortisol, and sex steroids. So zona glomerulosa produce mostly aldosterone, fasciculata produce mostly cortisol, and reticularis produce mostly sex steroids. So I remember it's as GFR, right? So it's an acronym that we use. So again, when we talk about adrenal hormones, we talk about adrenal cortex. Now, let's go back to this principles of endocrinology that I mentioned in the first lecture, right? So pituitary gland is the master of the glands, right? So it's controlled by hypothalamus. Hypothalamus releasing hormone, stimulate pituitary gland to release a stimulating hormone that stimulates an endocrine gland, right? An endocrine gland produces hormones, which binds to the target organ receptor and complete the feedback loop, right? For the now, in the first lecture, we talked about HPG axis, right? Hypothalamic pituitary gonadal axis. This time we're talking about HPA, right? So hypothalamic pituitary adrenal axis. So hypothalamus secretes CRH. CRH stimulate pituitary to secrete ACTH. ACTH then stimulate adrenal gland to secrete adrenal hormones. Right? Remember, there are three zones, or there are three types of hormones being secreted. Right? So, when we talked about in previous lecture, right, anything that happens at the adrenal, we call it primary adrenal disorder, right? The unit of hypothalamus and pituitary, we call it secondary or central, right? It's the same name, secondary or central, right? So as I mentioned earlier, there are three hormones, right? So adrenal cortex secretes cortisol, aldosterone, and androgens, right? Or sex steroids. Cortisol binds to glucocorticoid receptor, or GR, right? Aldosterone binds to a mineralocorticoid receptor. And androgen binds to the same receptor as testosterone. We call it androgen receptor, as a group of receptor respond to sex hormone. Also, aldosterone can be stimulated by renin-angiotensin system. Remember, renin-angiotensin can stimulate aldosterone. This will come into play when we talked about secondary adrenal insufficiency, because aldosterone can still be stimulated by the renin-angiotensin system. Right? Remember this special pathway that can stimulate aldosterone production. So when we talk about adrenal hormones, we often divide it into the action of two main hormones, right? Cortisol and aldosterone. What does cortisol do? Cortisol is a stress hormone. It's one of the most important hormones in response to stress, right? It maintains your blood glucose, maintains your vascular tone, and so many other functions of cortisol. So it's very important. Aldosterone, on the other hand, it plays a major role in electrolytes abnormality, electrolytes balance, especially sodium and potassium, right? So it preserves sodium and it excretes potassium. Now, we used to think that aldosterone receptors only in the collecting tubules. Now, we found that it's also in distal convoluted tubules in the kidney, right? So majority of aldosterone receptor exists in the kidneys. So it also is important for acid excretion by the principal cells, right? This is the reason why when you have adrenal insufficiency, primary adrenal insufficiency, when you have aldosterone deficiency, you can have metabolic acidosis as well, right? So as you see, these two hormones are so important for metabolism, maintaining blood pressure, maintaining electrolytes for our system. Now, you probably heard about this diurnal variation of cortisol production, right? So it is the highest in the morning. Why? Because the peak ACTH occurs around 4 o'clock in the morning, right? So that means your peak cortisol production is a couple of hours later. So the peak cortisol production is between 8 to 9 o'clock, but most people say 8 o'clock in the morning, right? And then it goes down throughout the day, right? And then it's the lowest at night, right? So this is the reason why when we want to check the cortisol level, whether that person is adrenal insufficiency or not, we always do in the morning, right? As a screening test. So where do we check? We check at the peak, at the highest level, right? So we check fasting morning cortisol as a screening to see whether does that patient makes enough cortisol or not. However, this diurnal variation is not mature until 2 years of age, right? So as you remember, every time we did a consultation in the NICU, it's very difficult for us to comment on a cortisol level in newborns, especially preterm infants, right? So we don't know when is the peak. It doesn't happen yet. So what we do, we probably do our best estimate, right? So we do before feedings. Remember, when you start feeding, when you start having glucose in the system, it suppresses your glucocorticoid, right? So we always do the closest to the next meal, right? So that's our best estimate, right? So again, I've been stressing the importance of the history and physical exam, because again, in endocrinology, without history and physical exam, we cannot really make a interpretation of our laboratory results. Now, if you ask me, what are the symptoms of adrenal insufficiency, is very broad. If you look in a textbook, it's a long list because some of these are so non-specific, right? Patients can have rapid weight loss, they can become fatigued and with the hyperpigmentation, or they can have hypoglycemia, hyponatremia, hyperkalemia, and acidosis, and not necessarily the combination of both hyponatremia or hyperkalemia. Patients can just have hyponatremia. I've seen patients with Addison's that present with just hyponatremia. Okay. Also, you may suspect central adrenal insufficiency if the patient has brain lesions, like either brain tumor or had brain surgery or received brain radiation, right? Because we know that it's a radiation injury to pituitary, which is going to cause central adrenal insufficiency, right? In the newborns, common signs are hypoglycemia. In a severe case, you can have hypotension, electrolytes abnormality. We're going to come back to this when we talk about CAH, right? Because CAH is a form of a primary adrenal insufficiency that is caused by a mutation in the enzyme that synthesize adrenal steroids. Or we also have a group of endocrinopathy that is known to associate with adrenal insufficiency. These are autoimmune type, right? Such as type 1 diabetes, Hashimoto thyroiditis, right? There's a group of um, endocrinopathy, we call it autoimmune polyendocrinopathy, caused by autoimmunity to many endocrine glands. So patient can present with type 1 diabetes with Addison's and Hashimoto combined. Now, let's talk about the primary adrenal insufficiency, which I think comes up more often in the board, right? So think about the axis that we looked at, right? Hypothalamic, pituitary, adrenal axis. The problem is at the adrenal. So what would happen? You have very low cortisol, and at the same time, because of low cortisol, it sends a positive feedback to hypothalamic pituitary unit to stimulate the ACTH production, right? So the typical laboratory finding is you're going to see low cortisol with elevated ACTH. And when I'm talking about elevated, it's in the thousands. Now you also remember, the adrenal gland doesn't make enough aldosterone. What would happen? So you see an elevated plasma renin activity, right? Now, we mentioned a lot about hyperpigmentation that occur in the primary adrenal insufficiency, right? What causes it, right? So remember, you have very low cortisol, right? Cortisol then a low cortisol has a positive feedback to pituitary gland. So pituitary gland doesn't just secrete ACTH, it secretes a protein called POMC, right? It's pro-opiomelanocortin, which is a long peptide, which is then cleaved into smaller peptides, right? So one of them is ACTH, and the other one is melanocyte stimulating hormone, MSH. And this is the one that stimulates the pigment in the skin, causing hyperpigmentation, right? POMC also, it's cleaved to another hormones. One of them is endorphin, right? We're not going to go into details, but I just wanted you to know why a low cortisol positive feedback cause a stimulation of MSH secretion and cause hyperpigmentation, right? So these are the signs that you see. It's described as a golden color, right? Skin. And it's usually in the creases of the skin, right? The nape of the neck, also in the gum, right here is the hyperpigmentation you see in the gum. Now, some of the causes of adrenal insufficiency that you should review. Most of the time, the board exam doesn't really ask you what is the cause of that primary adrenal insufficiency, because there are many of them, but they usually focus on you being able to diagnose adrenal insufficiency, right? So some of the etiologies, congenital, remember, you can have a genesis of both adrenal glands. Now, this condition, we have a fancy name called adrenal hypoplasia congenita, AHC. Now, it's different from the other congenital form, which is called congenital adrenal hypoplasia, or CAH, right? So we're going to be talking more about this in the second video, focusing on CAH. Now, you can also have an infection. Do you remember which pathogen caused primary adrenal insufficiency? Meningococcemia, right? So it's a very classic presentation, right? So after meningococcemia, they have massive adrenal hemorrhage, and they later develop primary adrenal insufficiency, right? Or you can have a bilateral massive adrenal hemorrhage, right? So it has to be bilateral and has to be massive, right? So we get called a lot from the NICU regarding the finding of adrenal hemorrhage, right? Most of the time, it doesn't turn out to be real adrenal insufficiency, because remember, we have two adrenal glands, and it has to be really big big enough to affect the function, right? Now, the most common cause is Addison's disease, right? So remember, I'm going to be asking about Dr. Thomas Addison. He's a British physician who described Addison's disease. There is another hematologic condition. We all know about it. It's also described by Dr. Thomas Addison. I'm going to be asking you in a quiz. So look up which hematologic condition is that. Primary adrenal insufficiency can also be caused by certain toxic substances, right? The common ones are ketoconazole. Why does it do that? Ketoconazole actually blocks the cortisol production. One of the enzymes can be blocked by ketoconazole. Mitotane, right, remember, is a DDT derivative, right? DDT is an insecticide. So mitotane is used in adrenal cancer, right? Because it can block, adrenal function. Now, this is a kind of cartoon depicting the symptoms you can see in Addison's disease, right? So as we mentioned before, you can have a brown pigmentation of the skin. You get a, changes in distribution body hair. You don't feel well. You're very weak. You're fatigued. You have weight loss. You have postural hypertension. So the symptoms sounds very, very vague, right? So I can tell you, many of these Addison's disease patients were diagnosed with something else. Some of them have been diagnosed with some psychiatric disorder. Some of them were diagnosed with depression, and then turn out that they actually have Addison's disease. Also, salt craving, right? So I have a patient that when she develops Addison's, she's been eating 1 jar of pickle a day, right? So salt craving, right? Why? Because you start losing sodium, so the body try to increase the sodium level by the increase in intake. So, what about secondary adrenal insufficiency, right? Central adrenal insufficiency, not as common as primary. However, there's another condition which is called adrenal suppression. It's considered secondary adrenal insufficiency, right? We're going to be talking about the next slide. But let's talk about a condition that can cause, let's talk about hormonal changes first. Remember, this is a central unit, right? Hypothalamic pituitary unit doesn't make enough ACTH. So what you're going to see low cortisol and low to normal ACTH, right? It doesn't have a robust response, right? Primary, right? And remember, renin-angiotensin aldosterone is intact, right? So renin-angiotensins can stimulate aldosterone production, right? So this is important because when you diagnose someone with central adrenal insufficiency, you don't have to start that person on mineralocorticoid, right? Because the renin-angiotensin aldosterone is still intact. And again, you've probably heard about an ACTH stimulation test, right? Because sometime when you do a baseline cortisol is ambivalent, or you couldn't make a true diagnosis. Is that low? Is that low enough? So we use a synthetic ACTH, right, to stimulate the gland to produce the cortisol. So we measure the cortisol response to an ACTH. Right, so some common causes of central adrenal insufficiency, right? So hypopituitarism, right? You're going to see that on the board. Very common scenario. You're going to see they're going to describe a boy with signs of hypopituitarism, right? Such as hypoglycemia and micropenis, right? So when you see that, they often a suggestive of hypopituitarism. Now, Infection, not very common. Meningitis, you have to have a severe encephalitis to cause a central adrenal insufficiency, right? Now, when we talk about trauma, it's a trauma to the brain, to pituitary. So it's either brain surgery or brain tumor, right? Now, autoimmunity is not very common. There is a condition, it's called hypophysitis, which is a autoimmune to the pituitary gland, right? It's so rare that we rarely see it. Now, when you talk about toxic substance, right? So it's radiation, right? I mentioned earlier, the most common cause of central adrenal insufficiency is actually an adrenal suppression caused by an excessive use of glucocorticoid, right? So we've seen that a lot. I think this is the most common cause of adrenal insufficiency overall, if you ask me. But if you want to be specific, it's actually a central adrenal insufficiency. So what happened, right? You use a glucocorticoid for a prolonged period of time, right? Remember, there are many types of glucocorticoid derivatives, right? You have prednisone, prednisolone, solomedrol, methylprednisolone, dexamethasone. So I'm going to be asking you which glucocorticoid derivative does not have mineralocorticoid activity, right? That is dexamethasone. All of them has some mineralocorticoid activity except dexamethasone, right? So what happened? So you use a glucocorticoid for a long period of time. Generally, we're talking about 3 to 4 weeks, at least 4 weeks before you start seeing the suppressive effect. Where does it suppress? It's suppressed. Remember, it has a negative feedback, right? Excess glucocorticoid suppress the production of CRH and ACTH. So ACTH, remember, it has a growth stimulating effect on adrenal. So what happened? Adrenal become atrophy, right? So after a prolonged use of an adrenal glucocorticoid, your adrenal become atrophy, right? So what happened? So when you suddenly stop the glucocorticoid, right, your adrenal is still atrophy, can't make enough um, glucocorticoid, right? So that's when you're starting having a signs and symptom of adrenal insufficiency, not when they're receiving it. However, during the time they're receiving it, they express the sign and symptoms of an excess glucocorticoid. What do we call that appearance? Cushingoid appearance, right? Remember, Cushing. I'm going to be asking about Dr. Harvey Cushing. Mm, look him up, read about his history. I'm going to be asking one question about Dr. Harvey Cushing, right? So he described it in 1912 when he's at Brigham Hospital, which is now part of Boston, Harvard Medical School in Boston, right? So he described what Dr. Cushing described is actually an pituitary adenoma that secretes excess ACTH, right? So you have an excess ACTH to stimulate an overproduction of glucocorticoids, right? So when you have excess glucocorticoid, this is happening, right? You have moon phases, you have stria, and you have many other signs that you can look it up, right? The Cushingoid appearance. So um, currently, when you have excess cortisol that is caused by a pituitary adenoma, we specifically call it Cushing's disease, right? However, Cushing syndrome or Cushingoid appearance is a general term describing signs of excess cortisol, not specifically said this is a tumor, right? So you can call a patient who's been using glucocorticoid and have Cushingoid appearance to have a Cushing syndrome, right? That's totally okay, but they actually have an adrenal, they're going to have a central adrenal insufficiency if you stop the glucocorticoid rapidly. This is the reason why we have to taper, right? So this is a little bit of a details about terminology because we use it interchangeably, right? The patient has Cushingoid appearance, right? The patient has Cushing syndrome, but it's not because of an adenoma, it's because of an excess cortisol, right? So remember, I'm going to be asking about Dr. Harvey Cushing as well, right? So, so this is the end of the lecture. We're going to be discussing cases during our academic half day, but I'm going to be coming back to some of these a basic knowledge. All right.